Hello everyone. Let's get back to our next topic, which is called inguinal canal. So inguinal canal is this oblique passage in the lower part of the anterior abdominal wall. The contents are important. It contains genitofemoral nerve, genital branch of genitofemoral nerve. Second is ilioinguinal nerve, and third is spermatic cord in male and round ligament in female. Genitofemoral nerve, ilioinguinal nerve, spermatic cord in male, and round ligament of uterus in female. What are the walls of inguinal canal? Again, you can read it. It's not very difficult, but anterior wall, external oblique, reinforced laterally by origin of internal oblique, posterior wall, conjoined tendon, medially, fascia transversalis laterally, roof of the superior wall, fibers of internal oblique and transverse abdominis muscle, and inferior wall, inguinal ligament, and medially by lacunar ligament. So if you look at this image, you will get a pretty good idea about spermatic cord. Next is Hazel-Badge inguinal triangle. What are the boundaries? So for this topic, Hazel-Badge triangle, the boundaries are important. They can ask you in the exam. Medially, lateral border of rectus sheet. Laterally, inferior epigastric artery. Inferiorly, inguinal ligament. And posteriorly, or floor of the Hazel-Badge triangle, conjoined tendon, fascia transversalis. So this is Hazel-Badge triangle. If you can see me drawing, so medially, so this is the medial side, and this is lateral. This is inferior. So medially, you can see rectus abdominis muscle. So lateral border of rectus abdominis is forming medial boundary of Hazel-Badge triangle. This is Hazel-Badge triangle. Laterally, you can see these are inferior epigastric vessel. Inferiorly, this is inguinal ligament. Let's look at another other image. So this is in green. This is Hazel-Badge triangle. Rectus abdominis, medially, inferior epigastric vessel, laterally, inguinal ligament, inferiorly. Next is hernias. We already discussed femoral hernia, but let's discuss other hernia. Basically, a protrusion of viscus or part of viscus to the defect or weakness through which organ usually do not pass. What is the risk? Incarceration and strangulation can happen. What is the presentation? They can have fever, abdominal pain, tenderness on palpation, erythema, swelling, all those symptoms. So the first is indirect inguinal hernia. When the abdominal content protrudes through deep inguinal ring, lateral to inferior epigastric vessel. When the hernia abdominal content protrudes through deep inguinal ring, lateral to inferior epigastric vessel, viscus passes through inguinal canal, exit through superficial inguinal ring, coil in the scrotum. So for indirect inguinal hernia, you need deep ring, superficial ring, inguinal ring, and then enters into the scrotum. More common in male. It is covered by all three layers of spermatic fascia. What is the cause? Pathology is failure of process vaginalis to close, and it can also cause hydrocele too. This is indirect inguinal hernia. You can see lateral to inferior epigastric vessel passes through deep ring, superficial ring, failure of process vaginalis to close, results in hernias. So abdominal content will protrude through this, and then they can coil around here. in the scrotum. And presentation will be pain, tenderness, fever, swelling. Next is direct inguinal hernia. It is caused by weakness in posterior wall of inguinal canal. Weakness in posterior wall of inguinal canal, and it is medial to inferior epigastric vessel. So that's why it is important to remember lateral and medial. So indirect inguinal hernia is lateral to inferior epigastric vessel, but direct inguinal hernia is caused by weakness of posterior abdominal wall medial to inferior epigastric vessel. You will, on presentation, you will see a bulge or swelling on the surface of the spermatic cord and through the superficial ring. It is covered by only external spermatic fascia, more common in old male. Why? Because of the weakness of abdominal wall. This is indirect. Okay, let's look at this image. So the indirect is lateral to inferior epigastric vessel. This is deep ring. But direct is here, which is medial to inferior epigastric vessel. Direct is more common in male, old male, caused by abdominal wall weakness, posterior abdominal wall weakness. It is covered by only one layer of fascia, spermatic fascia. This is covered by all three layers. It requires deep ring, superficial ring, both. It is lateral to epigastric vessel, inferior epigastric vessel. If someone has a history of trauma, they can more commonly have direct hernia. Now, what are the other types of hernia? Diaphragmatic hernia, important. So first they can ask you about the embryology. What is the cause? It is caused by defect in pleuroperitoneal membrane. Pleuroperitoneal membrane is a membrane which is responsible for the formation of diaphragm. If there is a defect in pleuroperitoneal membrane, then they can have diaphragmatic hernia. Second, they can commonly ask you, so that's, let's say this is right side, this is left side. So this diaphragmatic hernia is more commonly on the left side. Why? Because of the presence of liver on the right side. Hiatal hernia. Stomach herniates upward through the esophageal hiatus of the diaphragm. So this is diaphragm and this is esophageal hiatus. So if the stomach protrude upward through this ring, this is called hiatal hernia. And there are different types of hiatal hernia. The most common one are two of them sliding hiatal hernia, and second is paraesophageal. So let's look at those two hernia. So this is sliding hernia. So you can see that the esophagus is slide upward into the thoracic cavity. And this is more common. But if they ask you which one is more risky, then it is paraesophageal hernia, which is also called rolling hernia. Because this hernia, cardiac end of the stomach protrude upward and it has high risk of strangulation. That's why it's more dangerous. So what is more common? Sliding hernia. Common in old age with long history of GERD. Which one is more dangerous? Paraesophageal hernia, also called rolling hernia because of high risk of strangulation. So for paraesophageal hernia, the treatment is surgery. Hiatal hernia, it can be conservative management, but if the patient is not responsive, then surgery can be done. They will not give you any image. The only image they can give you will be this one. They will not give you X-ray or CT. So sliding hernia, we already saw it looked like hourglass stomach. In the paraesophageal hernia, the gastric fundus will protrude upward into the thorax. So it looked like hourglass. So this is hourglass like this. Next is anal region. So anal canal is about 1.5-inch long. Approximately it continues with rectum at pelvic diaphragm and distally open at anus. Puborectalis component of pelvic diaphragm pull the flexure forward, which help to maintain fecal continence. So anal region consists of anal sphincter. Internal anal sphincter consists of circular smooth muscle that surrounds the anal canal. Increased tone of the muscle is caused by sympathetic stimulation, and relaxation of muscle is caused by parasympathetic stimulation. Both external anal sphincter is controlled by pudendal nerve and relaxed during defecation. So internal sphincter, this one. External sphincter is this. What is pectinate line? So I'm going to tell you what question they can ask you from anal canal. They can ask you actually 3 or 4 questions easily, just from the anatomy and the blood supply and different kind of pathology related to anal canal. What is first you need to know what is pectinate line? It is formed where ectoderm meets endoderm. It is an elevation of mucous membrane at the distal end of anal column here. It's elevation of mucous membrane at the distal end of anal columns. Now, all the questions they can ask you, what can happen above the pectinate line and what can happen below the pectinate line. So first question they will ask you about blood supply. So they will give you a situation that patient present with bleeding per rectum, old patient, and bleeding is painless, and patient was diagnosed with adenocarcinoma, which is common above the pectinate line. And in the end, they will ask you the region which is involved in this situation or for this patient is supplied by which artery. So above the pectinate line is supplied by superior rectal artery, and below the pectinate line is supplied by inferior rectal artery. Venous drainage, superior rectal artery drain into inferior mesenteric vein, splenic vein, and then pelvic vein. Then inferior rectal vein drain into internal iliac vein, and then common iliac vein. Nerve supply, they will not ask you. Lymphatic, important. Again, important. Lymphatic, very important. So let's say if they gave you an answer that patient is diagnosed with adenocarcinoma of the rectum, but they will not mention above the pectinate line, below the pectinate line. And they will ask you what kind of lymph node are most commonly involved. Your answer will be internal iliac lymph node above the pectinate line. But if they tell you that it's a squamous cell carcinoma on biopsy after the test, which kind of lymph node will be involved? Superior inguinal lymph node. Above the pectinate line, if the patient develop hemorrhoid, they will be painless. Why? Because of visceral innervation. And they are painful below the pectinate line because they have more risk of thrombosis. So all the questions they will ask you is basically above and below the pectinate line. blood supply, venous supply, lymphatic is very important. What kind of carcinoma? They can ask you about question about that too. That patient present with painful bleeding going on for a few months. Patient has some weight loss. Superior inguinal lymph node is involved. What kind of cancer you are suspecting? Biopsy is already done, but what kind of cancer you are suspecting on biopsy? So if it is below the pectinate line, patient has painful thrombosis, bleeding, weight loss going on for a few months, squamous cell carcinoma will be your answer. And if it is otherwise, painless bleeding for months, internal iliac lymph node is involved, adenocarcinoma. If they ask you which one is more common between these two, adenocarcinoma is more common. Adenocarcinoma is more common. External hemorrhoid. Above the pectinate line here is internal hemorrhoid.